Hi, you're still here. We are now in the part 5. Let's continue with the chronic or recurrent appendicitis. Chronic or recurrent appendicitis. Patients with recurrent right lower quadrant abdominal pain not associated with febrile illness with imaging findings suggestive of an appendicolith or dilated appendix are classified as having chronic appendicitis. Patients often report resolution of symptoms with an appendectomy. In the absence of imaging abnormalities, prophylactic appendectomy is not encouraged. So that's it for chronic and recurrent appendicitis. Last topic is the outcomes and post-operative course. Appendectomy is relatively safe procedure with an extremely low mortality rate, less than 1%. The commonest adverse events include soft tissue infections, either superficial or deep, including abscesses. Patients with uncomplicated appendicitis do not require further antibiotics after an appendectomy, while patients with perforated appendicitis are treated with 3 to 7 days of antibiotics, but 4 days from the Stop-It trial. Patients with wound infection can be managed with simple wound opening and packing, and delayed primary closure has not shown to be beneficial. In laparoscopic cases, these are usually the periumbilical ports. Patients with deep space abscesses are managed with percutaneous drainage and antibiotics. Fistulas, appendicocutaneous or appendicovesicular are managed conservatively as the first step. Bowel obstructions and infertility are infrequent, but they are reported. For the stump appendicitis, an uncommon complication after surgery is the development of appendicitis in an incompletely excised appendiceal stump, greater than 0.5 cm stump length. Optimal management requires re-excision of the appendiceal base, but diagnosis can be difficult and requires careful assessment of patient's history, physical exam, and imaging studies. Use of the appendiceal critical view, appendix placed at 10 o'clock, taenia coli libera at 3 o'clock, and terminal ileum 6 o'clock, and identification of where the taenia coli merge and disappear is paramount to identifying and ligating the base of the appendix during the initial operation. In patients who have had prior appendectomy, a low index of suspicion is important to prevent delay in diagnosis and complications. Prior appendectomy should not be an absolute criterion in ruling out acute appendicitis. Appendicial neoplasms. The incidence of appendicial neoplasms is estimated at around 1% of all appendectomy specimens. Although the true incidence of appendicial neoplasm is not known, neoplasms that can occur in the appendix are predominantly gastroenteropancreatic neuroendocrine tumors, or the GEP-NETs, previously called carcinoids, mucinous neoplasms, or adenocarcinomas. Almost one-third of the neoplasms of the appendix present with acute appendicitis, while the other are often incidentally detected or detected after regional spread of disease. So that's it for appendiceal neoplasm. Next in line is the gastroenteropancreatic neuroendocrine tumors, or the GEP-NETs or carcinoid. Appendiceal carcinoid tumors are submucosal rubbery masses that are detected incidentally on the appendix. Carcinoid tumors of the appendix are relatively indolent but can develop nodal or hepatic metastases. Infrequently, these can be associated with carcinoid syndrome if there are hepatic metastases, 2.9%. Upon incidental findings of the suspected carcinoid, the surgeon must evaluate the nodal basin along the ileocolic pedicle and also examine the liver for any signs of metastasis. For lesions that are less than 1 cm, 95% of all lesions, a negative margin appendectomy is adequate. For tumors 2 cm or larger, a right hemicolectomy is recommended. For lesions 1 to 2 cm in size, there is no consensus on a completion colectomy. A right colectomy is often performed for mesenteric invasion in large nodes or positive unclear margins. Measurement of serum chromogranin A is recommended. So that's it for GEP and ET. Next, the goblet cell carcinoma. These lesions were mistakenly called goblet cell carcinoids, implying a rather indolent biology. While goblet cell carcinomas are adenocarcinoid with both adenocarcinoma and neuroendocrine features. Such lesions carry a worse prognosis than carcinoids, but slightly better than adenocarcinoma. There is a high risk of peritoneal recurrence in such cases. For incidentally detected lesions, a systematic surveillance of the peritoneum must be performed, and a peritoneal cancer index score must be documented if disease is present. In the absence of metastatic disease, a right hemicolectomy is generally appropriate. Although some advocate a right colectomy, in the absence of metastatic disease, a right hemicolectomy is generally appropriate. Although some advocate for a right colectomy only for tumors 2 cm or larger. Lymphomas. Another topic, lymphomas. Appendiceal lymphomas are rare, 1 to 3% of lymphomas, usually non-Hodgkin's, and difficult to diagnose preoperatively. Appendiceal diameter can be 2.5 centimeters or larger. Management includes appendectomy in most cases. Next is adenocarcinoma. Primary adenocarcinoma of the appendix is a rare neoplasm with 3 major histologic subtypes. We have mucinous adenocarcinoma, colonic adenocarcinoma, and adenocarcinoid. The most common mode of presentation for appendiceal carcinoma is acute appendicitis. Patients also may present with ascites or a palpable mass, or the neoplasm may be discovered during an operative procedure for an unrelated cause. The recommended treatment for all patients with adenocarcinoma of the appendix is a formal right hemicolectomy. Appendiceal adenocarcinomas have a propensity for early perforation, although they are not clearly associated with worsened prognosis. Overall, 5-year survival in this condition is 55% and varies with stage and grade. Patients with appendiceal adenocarcinoma are at significant risk for both synchronous and metachronous neoplasms, approximately half of which will originate from the gastrointestinal tract. So that's it for the adenocarcinoma. Next is appendiceal mucosals and mucinous neoplasms of the appendix. The term appendiceal mucosal broadly describes mucus-filled appendix that could be secondary to neoplastic or non-neoplastic pathologies, such as mucosal hyperplasia, simple or retention cyst, mucinous cyst adenomas, mucinous cyst adenocarcinoma. The most common form of presentation is incidental. However, presentation with appendicitis occurs in a third of cases. On cross-sectional imaging, a low attenuation round well-encapsulated cystic mass in the right or quadrant is often encountered, and features such as wall irregularity and soft tissue thickening are suggestive of neoplastic process. It is important to carefully assess the presence of ascites, peritoneal disease, and scalloping of the liver surface on imaging upon initial evaluation. A reliable diagnosis cannot be established using imaging alone, and it is recommended that surgical excision without capsular disruption is undertaken. The importance of careful handling of a mucosal and the avoidance of rupture cannot be overemphasized because the intraperitoneal spread of neoplastic cells and subsequent development of Pseudomyxoma peritone are nearly certain in cases of adenocarcinoma. So that's it. When suspecting mucinous neoplasm of the appendix, it is imperative to systematically examine the peritoneum and document a peritoneal cancer index if mucin is present. Biopsies to examine the content of epithelial cell, neoplastic cells, and mucin can be helpful. In cases where a homogeneous cyst without nodularity or signs of dissemination is encountered, laparoscopic excision is acceptable, provided that a stapler is fired across the base of the cecum to avoid a positive margin. The specimen should be placed in a plastic bag and carefully removed through a small incision. In the absence of mesenteric or peritoneal involvement, an appendectomy with concurrent appendiceal lymphadenectomy is sufficient, as the chances of lymph node involvement are quite low. If peritoneal spread is evident upon exploration, it is important to obtain biopsies and document the peritoneal disease burden. An appendectomy is acceptable if the patient has acute appendicitis, but suboptimal debulking is discouraged. In addition, colorectal, ovarian, and endometrial cancers can coexist in the setting of appendiceal mucosals, and careful examination of intra-abdominal structures is important. When there is discordance between the primary lesion histology and the peritoneum, the peritoneal histology is usually given priority. For instance, if patients have neoplasm in the appendix but adenocarcinoma in the peritoneum, the patient would be considered as having adenocarcinoma, AJCCM1B disease. The recent AJCC 8th edition and the PSOGI 2016 classification consensus has resulted in a therapy-directed classification of mucinous neoplasms of the appendix, and it is summarized in Table 30-4. So you need to check that out. Okay? Last subtopic for the appendix, chapter 30 of Schwartz, is the Pseudomyxoma peritone syndrome, or the PPS. Pseudomyxoma peritone syndrome. Patients with appendicial mucinous neoplasms develop peritoneal dissemination, leading to Pseudomyxoma peritone syndrome. This can occur in gastric, ovarian, pancreatic, and colorectal primary tumors as well. Patients with this syndrome can vary prognosis, ranging from curative to palliative. Cytoreductive surgery and hyperthermic intraperitoneal chemotherapy, or HIPEC, are considered as a standard of care for patients with PMP syndrome from appendiceal primaries. Early detection of management of limited peritoneal disease is favorable and preferred as opposed to extensive intraperitoneal mucin development. The surgical techniques involves parietal and visceral peritonectomies and intraperitoneal administration of heated 42 degrees Celsius or 108 degrees Fahrenheit chemotherapy, and usually mitomycin in the abdomen. Previously considered a morbid surgery, high-volume centers and standardized practices have made the morbidity and mortality similar to any major open GI procedure. This technique can also be performed laparoscopically when the disease is detected early and is low volume. And we are now done with the chapter 30, the appendix. Thank you so much for staying with me. I hope this will help you a lot. Thank you so much. Bye. See you for the next topics. Bye.